what we're gonna do right now is I've got Bassem here as my assistant. We're gonna go through just a minimally invasive pedicle screw fixation at L4-5. So this technology, a couple things to notice right off the bat. Number one, the device itself is on wheels. You can bring it into the operating room, wheel it up to the table, do a case, push a button, unlock the casters, wheel it to another room, and then you're off to a second case, bring it back to your room. So the workflow, again, is such that the device can be brought in and out of a room or multiple rooms on a given day. It's not attached to the bed at all. So a couple of interesting things that we talked about during my talk about what are the imaging paradigms. So there are 3 different ways you can register the patient to the robot. The first way is with just plain x-ray. So you can get an AP and a lateral x-ray, and you can actually plan screws based on that. You can get preoperative CT, which is the workflow I've gone to. And the nice thing about preoperative CT in adult degenerative cases is that once that CT is done, I can plan on a tablet the morning of the surgery, I can plan the evening before surgery, and that the planning is all done. Once we get into the operating room, we're good to go. Or the third paradigm is to have intraoperative cone beam CT, whether it's the O-arm, the Arrow, the Zigo, whatever it is. And those are the 3 different ways. So at this point, what I'm going to show you is the fact that we've got everything planned here for an L4-5 pedicle screw fixation. So we can see here the screw at L4 planned on the left side, on the right side. The nice thing is that in the planning mode, if I want, I can basically make changes in surgery. So you're not married to a given plan. So if in surgery I decide I want the screw to be a little bit more inferior, or let's just say the screw here, I want it to be longer because 50 looks a little short, let's go to 55. So I've found now that I'm making and planning implants to the exact size and specification of the patient. So that planning has been done. Registering, in this case, for a preoperative CT, requires getting an AP and lateral x-ray. That AP and lateral x-ray is then transferred to the robot, and once the CT and the x-ray are merged, we're able to navigate. So here you see in the lower left-hand corner of the screen here, you see the x-ray, you see the top of the CT. So those x-rays are obtained, AP and lateral, for the levels that you want to instrument. And then once those are registered to the CT scan, you get a check mark that shows that the registration is adequate, and then you're ready to navigate. So at this point, we're in the navigation page. So we're gonna go to left L4. And there's a pedal, which you can't see. I'm gonna step on the pedal, and the robot's gonna go and move to the left L4 targeted pedicle. And what we're gonna do in this case is we're going to take a marking pen, and we're gonna make a small mark on the skin. So the nice thing about this is you're able to plan your incision perfectly without having to guess where you need to make an incision. So the robot is now in place. So Bassam's gonna drop a marking pen through. This is the left L4 pedicle. Make a little mark on the skin. We'll do left L5 now. Oh, hold on one second, let's just do this. We'll connect them after. So now I'm gonna target the left L5 pedicle. And it's always interesting, sometimes you're thinking to yourself, well, is this right? The reality is that this is taking you down. You can see on that screen as that robot goes down, once that grid turns green, as it just did, that means you're locked on trajectory. That means you are good to go, and that trajectory is perfectly locked in image-guided way. So we'll mark that, Bassam, just through that. So we've got two dots on the skin which are sort of close to each other. We'll do the right side. And what we'll do with those dots on the skin is we'll just plan an incision that incorporates both entry points. The other thing to think about, obviously, is if you're doing a T-lift, you want to make sure that you're a little bit more medial, for instance, so that when you dock your tube for the decompression, you're not fighting. The nice thing about the technology, obviously, since it's real-time image guidance, what you're able to do is use image guidance to help you dock your retractor tube in the most precise way. So we can make a mark there. So we've targeted now the left L4 pedicle. And now we're moving to the left L5. So once we have the entry points for those, and again, just with the mark, you can see that if you can't see, the dots are fairly close together. Go ahead. So at this point, what I would do is I would just we'll plan an incision based on the incorporation of those two dots. So a knife. I make paramedian incisions. You can make stab incisions as well. Don't bump that. And go through the spread and go through the fascia. So make sure that you go through the fascia. What you don't want is the robot to be deflected by the fascia. And I'm going to show you as you drill sort of what's happening here. So we're going to go to the left L4. You don't really need a retractor. My favorite Seinfeld episode. Will you be using a retractor? You don't need a retractor here. So the thing that we worry about, obviously, when we're doing something percutaneously is drill deflection. Oh, hold on one sec. Come back down. Okay, so we're locked on trajectory. Place your drill. The drill has fiducials on it, so the drill is going to be image guided as well. And what you're seeing now is on the screen here is that the drill is going right down that trajectory. The bone is very soft, and the drill actually went down by itself. The drill has about a 30 millimeter stop on it. You cannot drill too deep. You drill down 30 millimeters, and then you're going to put a screw in. So I don't tap anymore. I don't use a ball tip probe. So go ahead, Bassem, just drill, and it will stop at the bottom. You're watching the drill in real time. And then when it's bottomed out, which you have, you're done. Back out. And then we're going to take the screw. You see we're still green, locked on trajectory. How does that feel?
Very easy, very smooth.
So you see a check mark on that left L4. The check mark means that you've affected the plan. We'll pop this up, unscrew this, and we'll go to the L5 on the left side. And you see it comes off the tower here. Again, to avoid any sort of collision. Oop.
If you need a strong arm, the robot's BAS is pretty powerful.
Say again?
BASM is very powerful if you need to strong arm that robot.
Yeah, so the arm itself can withstand 150 pounds of force, and the fact of the matter, 180 pounds of force. So the fact is that if you bump into it, and when it's attached and the casters are down on the table, you can't move that arm at all. So let's see.
Okay, if I ask a question, Nick?
Yeah, please.
So how fine cut does that CT have to be if you want to use for your pre-registration a preoperative CT scan?
So the scan thickness is probably 3 millimeter cuts are fine.
Are helical CTs detailed enough to allow for sufficient resolution?
So, say again?
Helical CTs, multi-sensor CTs okay for that kind of an image quality that you need?
Yes. So pretty much any CT scan works with small cuts. So, let's do this out of curiosity. Let's make this incision over here, Bassem, for 1 sec. Move your knife. Go ahead and make that incision there. Do what now?
Can you share with us your thought processes as you're troubleshooting right now, Nick?
One more time, yeah, Jens?
Can you share your troubleshooting thoughts with
Yeah, so we're all beholden to technology and software. So most of the time, these little errors that will come up are software issues. And the fact of the matter is that you can always go back. You're never going to lose anything in this paradigm. So in other words, if something happens, something gets bumped or something moves, there's always a step backwards that you can go to sort of get back to where you need to go. And at this point, again, let's see here. Yeah. So we're still getting an error code here. So, every once in a while this will happen, and I wish I could tell you it's never happened before. It does happen. And what we'll do is we can go back and just backwards one step. Yep. So but at this point, what we would do is we'd go to the second level. Again, we'd target the pedicles. And then what I would do after the screws are placed is we'd take a image guided wand, be able to find out exactly where we are in space, dock the MIS retractor, and then be able to do our T-lift. Utilizing that feedback from the image guidance in real time to know where we are. How long is that going to be? Yeah. There we go. All right. Here we go. It's acting up on us a little bit. The other thing is you should talk nicely to it. Sometimes you have to pet it and stroke it a little bit just to make sure that it's going to follow your thing. So we're docked now at left L5. So Bassem's going to go ahead and drill again. What we're watching now in real time is the drill hitting the entry point of the pedicle. Okay, perfect. Again, we have a screw plan 6.545. We'll go right through that trajectory. Perfect. I'm waiting for the check mark. There you go. And this comes up and that just unscrews here. And I just lift it straight off. We'll do the other side.
So Nick, as you're doing the other side, did you then pre-plan all of those screws before the surgery? So
Yes, so you can plan them, but you can make adjustments, Jen, in the surgery. So for instance, right now, if I didn't like the way this left L4 or right L4 screw was placed, I would go back to plan, and I could make an adjustment on the fly and make a more medial or more lateral trajectory. So if you find that things aren't going to add up, so the nice thing about this lower left-hand corner is, or the upper left-hand corner, I should say, on this screen, is that you get to see a representation of how the screws line up. For a single-level construct, it's irrelevant. But when you have a multi-level construct, it becomes a big deal when you're putting screws if things aren't lining up. So you have the ability to tweak things a little bit to make things line up. That's one benefit. The second benefit, of course, is if you're doing something and you realize that you want to change, it's a bony anatomy, there's a bone island, we're skiving a little bit. The fact of the matter is that you're able to do that. So we'll go to right L4 now. Oh, sorry. That's my hands in the way. So the one, of course, the one complicating feature with any sort of image guidance is being in the way of the navigator. So the pelvis fixation has to be in real time seen with the camera and the robot, and those things need to be triangulated. Go ahead. So we got our pre-planned screws. So Now, do you have to plan before the surgery? No, because if you're using an O-arm, you can plan during the surgery itself. From a workflow perspective, this slows you down a little bit. If you're doing a planning in surgery, you're perfect. If you're doing planning in surgery, that does take an extra 2 or 3 minutes of time. With the preoperative CT, at least in the adult degen population, the nice thing is that it's pretty quick. And again, like I said, I don't do it the night before, but certainly the morning of, right before surgery is a good time to do that.
So I have a question for Basem.
Yes, Jens.
When you insert those screws, do you still have a proprioceptive feedback that you're engaging bone properly? I know you have a very osteopenic deformity patient with mixed osteolysis and osteodense areas, but how's your proprioceptive feedback?
I mean, when you drill down the screw, you really have a proprioceptive feedback, and this is something I would not have expected personally, but now doing this procedure, I have always a good feeling that I have a good purchase and I'm not off.
Mm-hmm. And another question to Dr. Theodore. What is your actual fiduciary range here? Is it like 2 or 3 millimeters? Is it 1 millimeter? What are you experiencing? What can you share with us?
As far as accuracy goes?
As far as accuracy goes.
So, in the testing, we're in the 1 millimeter range and some sub-millimeter accuracy. The reality is that, that has a function of how far you are away from your target. So the farther you get away from that, theoretically, you do have some degradation in accuracy. But the reality is that once the patient is fixed, very little moves. So the other thing that's a good point, Jens, is you're not doing your osteotomies first. I'd place my hardware first, and then I'm doing any sort of corrective maneuvers and changing the alignment or morphology of the spine, because you want to make sure that those things don't move. Once the patient's positioned, really things don't move. Basem, you're feeling the screw going in?
Yes, I feel it, absolutely.
So, here you're watching in real time. So there's 4 screws placed with a little bit of a software hiccup in about 4.5 minutes. And I will tell you that, somebody said at a meeting I was just at, nothing ruins your day more than a post-operative CT in an MIS case. I'm more than happy to scan this, and I've every reason to believe it's gonna be perfect. So once the screws are in, at least for the MIS TLIF, I would basically pull the robot out of the way. And I would we have a wand? We have a chicken foot wand? All right, just give me a tap, if you would. Thanks, Steve. So at this point, you could use, real-time image guidance, and I would say, okay, I want to dock my retractor at the disc space, at the facet junction for the TLIF. This is also very nice from a teaching perspective, and obviously from a, getting it right the first time perspective. You're working a deep hole. We just did a patient the other day with a BMI of 50. God help me, when I saw her in clinic, I didn't think she was that big, with a 110 millimeter tube, but docking exactly where you want that retractor to go. You can envision, and it's not it won't be in the too distant future, that the arm itself will hold the retractor and will be able to come in for you into that trajectory for you to do your decompression. You can envision, again, in the not too distant future, that a robotic arm will help you with drilling, will help you with osteotomies, will help you with your PSO, et cetera. That's all on the table. But utilizing the real-time image guidance. And the other thing is placing an implant. So if you're placing your TLIF, I can take the pointer device, put it into the disc space, know exactly where I am in the disc space, how far across I am, the midline, et cetera, for placing an implant. Having tracked implants will be coming out soon as well. And the reality is that's just going to make this even easier. With 4 screws placed and the retractor docked, the fact is, when I bring the microscope in, 25, 30 minutes of drilling out that facet. We need to do a central decompression, the medial lamina, and essentially putting your hardware in. So, skin to skin now, MIS TLIF with 2 incisions now is, again, reliably 2 hours or less.
So let me just ask you a question again. So in this model right now, your L405 instrumentation, you're referencing this live off of the fiduciary implant that was placed in the ilium or sacrum there?
Right. So we get the camera to where my hands are here. There are 2 things to notice. This is the dynamic reference array. The neat thing about this is, and this is the bane of image guidance, if this gets bumped, you see we've lost our surveillance. And the fact of the matter is that, the neat thing is that it is built to be able to have some movement. And if your suction or Bovie cable gets caught in this and it gets clicked off, you can click it back until your surveillance comes back green. The other thing is this surveillance marker. And I always, when I did image guidance, when I was first learning to do image guidance, it always, we were beholden to not moving this reference array. And we know that if it moved, you're done because you don't know what's happening on the inside. Your registration's gone. This one little tiny fiducial here also talks back and forth. So what you have is one extra piece of information. I want the highest level of accuracy, so I need to know if we're doing thoracic pedicle screws percutaneously, if something's off by a millimeter, I need to know. If this gets bumped, I know, but if anything moves between these two, so it's just one extra piece of redundant information that comes back to you to know whether you're to know whether you're off. The other thing just to show you for once, can we put the arm back on and just show the force sensor for 1 second?
Yeah, that force sensor is quite remarkable. This is that tracking device that basically allows you to register if you're skiving.
Correct.
That's
So one of the things is when you're drilling percutaneously, if you're coming down on a sharp piece of bone and that drill deflects, you need to know if that happens. And if you look, and if we can get the split screen up, there we go. Look at the force sensor. It says force, and as I touch the drill tip, you see, and I get a warning here. So as I'm coming down on the bone, if that tip, and I don't like to use the word skive, it's deflection. If that tip gets deflected from where you are, you're going to get feedback. So again, this is a little bit different way of doing surgery. Unfortunately, I can't tell you you're going to go in and everything is going to be perfect the first time, but you have feedback to be able to do things now, and you need a little bit different way of doing things. If you're watching in real time and you're doing an open case, you know if you skived. When you're doing something percutaneously, you have feeling, so Bassem told you that he's able to feel the drill as it goes in, but here we're getting real feedback in 6 dimensions of where that force is occurring, and if it's over a certain threshold that turns red, if that happens, you've got 2 options. You can go back to plan, and you can actually change the trajectory of the screw so it's not ending on a tip of a bone, or what you can do also at that point is back the drill up, either use a burr or what I'll do is I'll back the drill up off the bone. If it's skiving on a piece of bone, I'll back up, start the drill, and then put the drill through so that I've got some rotary motion going that's going to engage the bone. Obviously, again, you're not seeing in these cases exactly what's going on. So having that tactile feedback. And I will tell you that at this point now, from across the room, I can tell if the screw's in. You hear you'll see, and what you'll see also as you're putting the screw in is you'll see the force sensor jump, because if you're engaging good cortical bone, you're actually you're generating a small bit of torque, and that will actually be shown on the end effector of the robot.
Hey, a couple of quick questions, and I'll obviously want to ask the audience also. So you did this L45 instrumentation. I want to go back to the reference array that you have there. But let's just say Dr. Bess and I will do a long instrumentation for a scoliosis.
Sure.
Obviously, there's some mobility in there. How much or how often do you have to reposition those reference arrays to try to stay relevant? Let's say this is L45, but what about T12, L1 or so? Do we have to reposition?
No, so T10 to the pelvis, I'm pretty much using one, I'm not changing anything at all. I mean, we're pretty good. If I'm going T4 to the pelvis, sometimes what I'll do is I will in the secondary is put a clamp, a bone clamp on in the thoracic spine to register the upper half, just to increase your accuracy if it's an open case. But honestly, I have gone all the way up to T4 with one registration. Again, the screws go in first, and everything, it can't be this person has the other thing to bring up, and I do a lot of trauma, if somebody has a T12 burst fracture and is ripped apart at T12L1, you must register. There's that by definition, Jens, as you know, they're 2 different people. So I'll put the screws up to L2 and then skip the reference clamp and register the upper spine as a separate entity, because there's grossly unstable motion at the thoracolumbar junction from a fracture dislocation. In a routine degenerative case, most patients are, once they're on the table and fixed, they're not moving, and I have gone all the way up to T4. I would probably say the safest thing to do would be stop at T10, and then you can put your clamp on, re-register the upper part, which if you have a pre-op CT is 2 or 3 X-rays, and you're off to the races, really increasing your accuracy.
And a quick further follow-up, iliac crest. So this patient, for instance, this cadaver has very dysplastic-looking iliac crests. Are you comfortable registering and placing iliac screws with the current robot? And are the angles of freedom sufficient to allow for oblique screw placements?
So great question. So on the actual screen, when you bring the robot in, those boxes, which have check marks in them now, are green. They're green if you can hit the trajectory. So if I'm planning S2AI screw and L5, L4, L3, whatever, once the robot's, if all those things are green, you can hit those trajectories. So the beauty is, and you gave a beautiful demonstration of the S2AI screws, I'm not struggling anymore, I'm not shooting any more x-rays. Once that's planned, the robot will come. It's an unusual, it looks unusual, but the fact of the matter is that's the perfect example for a usage of image guidance is doing something like that, or iliac bolts, whatever or sacroiliac fixation, whatever you want to do. But once that's planned, robots are wheeled in, whether you can hit that trajectory, and it's usually not a problem. I've put in now, I don't know how many sacroiliac fixations, but it works quite well.
Final question, FDA restrictions, i.e. cervical spine or occiput or anything like that, could I use that in those areas with FDA clearance?
Yeah, so occiput, no, just because there are cranial applications to this robot for placing deep brain electrodes and doing brain surgery, not FDA cleared at this point, under submission. The reality is, though, from anything from C1 down to the tip of the coccyx, it's cleared. So FDA clearance for really the entire spine.
Well, we've seen the master demonstrate the tool. Any questions? Yes, sir. And to tell us who you are and where you're from.
I'm Ram Mudiam from Newport Beach, California. From a practical standpoint, are these systems married to certain implants as well, or are they based on a universal platform? And how do you convince a group of spine surgeons who have different implant preferences to buy a specific robot?
Well, as I like to say, spine surgery is like religion. If you ask any 3 spine surgeons, you're going to get 4 different opinions. So here's the take home. All the implants are pre-registered through the software, and really this is all about software. So can you use this with any system? Absolutely. The workaround is Kwires. I personally now have not used a Kwire in the last 3 years for any minimally invasive. So no Kwires, no cannulated screws, none of that. So it does work best with the implants designed for the robot. But certainly there are workarounds, and there are people that will place Kwires for that. So that platform is not open in that regard. How do you convince people to use things that they like to use and they're comfortable with? The reality is this has to be able to be of value to your practice and to your patients. So if this makes it easier for you to put those screws in, my next question would be, why are we married to a pedicle screw if there's technology that could potentially either collapse the time of the procedure or make it safer for our patients? And the third thing is, I will tell you, in teaching residents on a daily basis, my stress level has gone down. I'm usually standing holding, not Bassem, but holding the resident's hand as we're putting pedicle screws in. No, this way, this way, this way. Once everything's locked in, now that aspect of the case, which sometimes is stressful in those cases where the pedicles are 1 and 2 millimeters, that really goes down significantly. What we do every day is stressful enough. So.
Hey, Nick. Pat Johnson, have a question for you. As a follow-up to the last question, which was a great one. So for the less experienced person, which you are obviously the most experienced at this, would you recommend that people use Kwires, or what are the steps that you would recommend people that?
Yeah, that's a great question, Pat.
Experience, no robotics, no nothing. Kind of, what are the steps?
So the problem with Kwires are, I think we've all seen misadventures with Kwires all too many times, and you cannot. I mean, the whole problem with the Kwires, you can't control that distal tip. And if you're not doing it live, you have no idea where that distal tip goes. And having had personally complications with Kwires, and the reality is I'd like to get away from that. So I think that from an image-guided perspective, and you would be the one who would be able to speak to this because you're a master at image guidance, the reality is that once your trajectory is locked on, and if you're, again, you want to do things open, I did the first few cases open. And the fact of the matter is I needed to see for myself that everything was the way it was. You're going to have to trust, but verify. That's the reality. But I think going to Kwires is a step back, honestly.